This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're delighted that you're with us today. Today, we want to talk about and educate you, especially about health disparities, talking about traumatic brain injury, how it affects you, how it affects your family. We're delighted we've got Dr. Kathryn Hoes with us today. She's a neurosurgeon, spine surgeon, and she's on the medical staff at Texas Health Presbyterian Hospital, Dallas, and also at UT Southwestern. Dr. Hoes, welcome to the show.
Thank you each for having me. It's such a pleasure to join you today.
Well, we're delighted to have you, and for our listeners out there especially, can you define traumatic brain injury? And then secondly, how does it affect our bodies?
That's a great question. Traumatic brain injury is a broad spectrum of diseases. The most simplest way that I can explain it is a disruption to the normal function of the brain caused by an outward force. This can be a blunt force, such as a bump, blow, jolt to the head, or a car accident, fall from a bike or moving vehicle, or even a penetrating injury, where a sharp object pierces the skull and enters the brain. So based on the mechanism of what happens to someone, there are downstream effects that can be mild, moderate, or severe as we classify traumatic brain injuries. And with those mechanisms, other things such as swelling, bleeding, or dysfunction of the brain's normal activities occur downstream.
You know, in looking at traumatic brain injuries, we certainly realize that it doesn't discriminate and can happen at any age. And yet, the CDC has determined that the American Indian and Alaskan natives have higher rates of incident of traumatic brain injury. Do you know why?
We are always attuned to healthcare disparities, which are differences in the health outcomes and causes among different groups of people. It's interesting to note that their particular subgroups of the American Indian and Alaskan natives are at higher risk of TBI-related hospitalizations and deaths relative to other racial or ethnic groups. It has been speculated and studied, and what we've seen are that the things that underlie their disparities include higher rates of motor vehicle crashes, substance use, mental health disorders, or even access to appropriate health care. As one may imagine, being further from a center where one can be able to be cared for appropriately may decline one's health outcome when in need. They also have been shown to have a higher challenge in following up after release from the hospital.
You know, you mentioned that, and when we look at traumatic brain injury, which I'll now refer to as TBI, the CDC also said that non-Hispanic blacks and Hispanic patients are less likely to receive follow-up rehab treatment after an incident of TBI. From a clinical point of view, can you explain that?
Sure. We're actively trying to correct that, so we're looking into it very in depth. We found that some ethnic or racial minorities are more likely to have poor psychosocial, functional, or employment-related outcomes after a TBI relative to their non-Hispanic white individual counterparts. And we're looking to see what factors in the community level or system level we can use to overcome that. I'd like to be more thankful about how we've been approaching it lately. While we have people in our hospital systems who are more proactive in identifying these barriers, discussing it with the patient or their family, and helping them to bridge that gap before they leave our hospital system. So it's been definitely identified as a problem area to overcome, and we've made strides in that regard.
You know, that's really good to know that we're making strides. I'm going to pivot a little bit. You mentioned that there's a lot of different types of TBIs. From a clinical viewpoint and procedures that you perform, can you talk through some of the surgical procedures that are now in use maybe some that are on the horizon, so our listeners get a better grasp about some of the things you can do for TBI?
We have more tools at our disposal now than ever before. It's hard to believe, but advanced imaging such as CAT scans, which use x-rays to make a picture of the brain, or MRIs, magnetic resonance images, have only been around a relatively short period of time. Based on our clinical examination and what we see on imaging, we can have a picture in our minds as to what our patients need. And from there, we always proceed from least invasive, more conservative options to make their outcomes the best, on up to more aggressive things with their interest in mind. When someone has a traumatic brain injury, one common thing we often see is swelling, or an increase in the intracranial pressure known as ICP. If that is the case, we have to relieve that to prevent additional injury to the good surrounding brain, or the inflow of blood to prevent a secondary stroke. One thing we can do is called an ICP monitor, where across the skull vault, we place a small wire into the brain to tell us what the brain's pressure is, similar to how we would check a blood pressure. That's one of the procedures we can do right at the bedside in the ICU. Going up in the severity of injuries, if we identify bleeding, sometimes we need to do what's called a craniotomy, where we make a bone window to open into the skull and remove a blood clot. Sometimes, if it's very severe swelling, we do a craniectomy, where that bone window we leave out for a temporary period of time to allow the swelling to come and go, knowing that when the patient is healed, we can put the bone flap back, or a cranioplasty to help them with a cosmetic result and to move forward with their lives. So basics of hematoma evacuation, intracranial pressure and cerebral edema or swelling management, and decompressive craniectomy are some of the tools we have at our disposal. We're always looking for new options and innovative techniques to move our care forward in the least invasive and maximally helpful way.
That's an excellent answer. And as you were going through that answer, Dr. Hoes, I remember about 25 years ago, I had a good friend, and his son was 16 or 17. And he was spending the night with one of his buddies, and they were out horsing around. Anyway, he fell off the back of a car and hit his head on the asphalt, and he actually passed out for a few minutes. And when he came to, he said, "Hey, I don't want anybody to know this. I don't want to, get in trouble." Well, they went home, and he fell asleep. Luck would have this, the boy that he was visiting's mother was a neurosurgeon. She took one look, and immediately he had surgery right then, almost immediately, to relieve that pressure you were talking about.
That's pretty remarkable. He's very lucky to have the care he needed at that time. We're always looking for that critical moment to intervene, so I'm glad that happened for your friend.
We're talking with Dr. Kathryn Hoes, a neurosurgeon and spine surgeon on the medical staff at Texas Health Presbyterian Hospital Dallas and UT Southwestern Medical Center. When we come back, we're going to find out what that neurosurgeon mom saw when she looked at the boy and knew something was wrong. That's next on the Human Side of Healthcare.
This is the Human Side of Healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Thanks for joining us. We're continuing our conversation from the last segment with Dr. Kathryn Hoes, a neurosurgeon and spine surgeon on the medical staff at Texas Health Presbyterian Hospital Dallas and UT Southwestern Medical Center. From our story in the last segment, and if you didn't catch it, it's on our podcast, The Human Side of Healthcare, on all the major podcast players. But Steve told the story of a friend whose teenager came home after a head injury, and a friend's neurosurgeon mom knew that something was wrong. So, Dr. Hoes, what is it that she could have possibly recognized?
When we assess people with traumatic brain injury, as a neurosurgeon, it's almost a knee-jerk to use what's called the Glasgow Coma Scale, where we look for critical areas of interaction with the environment for the person that is suspected to have a traumatic brain injury. First being eye-opening. Is it spontaneous? Do they need stimulation to awaken? Can they maintain wakefulness at all? Then, verbalization. Are they able to talk to us in a coherent way? If not, is it words at all? Is it moans, or can they not produce speech? And lastly, when we interact with them, can they follow us to intelligence what we're talking about? Do they follow commands? Or are they showing signs of impairment, such as just reaching for where we're touching them, or even worse, showing what's called brainstem reflexes, where there can be posturing or abnormal movement showing duress, or that there's impending very severe intracranial pressure elevations. And any of those things would tip our radar to be more aggressive and seek urgent care, if not interventions. So I suspect when that neurosurgeon mother observed the young child, she saw an impaired level of consciousness and interaction with the environment to suggest that altered mental status, or even worse, a neurologic impairment where there was a physical manifestation such as an arm, leg not responding appropriately. Or we're also trained to look for seizure. Seizures people think of as generalized tonic-clonic convulsions, but they can be subtle things too that we know to look for, such as a focal movement of a hand, an absent staring off spell. So I'm wondering what constellation it was, but I'm pretty sure she was going down her list of emergent things to consider for that child.
I do remember this, Thomas, if this will help. But when he got home, he was talking kind of funny and he fell asleep. And the father said, "Have you boys been drinking? Have y'all been out drinking?" And that got the mother's attention. She came in. She noticed his eyes, his slurred speech. He was falling asleep. She did a quick assessment and turned to her son and said, "What happened?" And he said he fell off the car and his head hit the asphalt. So she picked up on almost all the things Dr. Hoes just said.
That's perfect. That's exactly right. One of the things that Hollywood often picks up on are pupil exams, but that is a last sign of extremis that we want to see is a dilated pupil. That is emergent go time for a neurosurgeon. So hopefully she wasn't seeing that too, but I'm glad she was there in the critical hour.
And to follow up on that, if someone has actually suffered from a TBI, or let's say they know a family member or someone that's a close friend, what should they take away from your discussion today?
Know that there are more resources for you now than there ever have been, and people are actively seeking to find you to make a difference in your life or the life of your loved one. There are a variety of people, such as therapists for physical therapy, occupational or engagement in activities, speech and cognitive therapists. There are rehab specialist doctors called physiatrists and physical medicine specialists, as well as people on the acute side, such as myself in neurosurgery, intensivists for critical care, hospitalists for routine health issues. We're all here in your camp waiting to help you. And we want to bridge the gap no matter where you are along the stage of your healing or helping your loved one.
I'm going to pivot just a little bit if I can. Can you tell our listeners things that you recommend they do to help prevent TBI? For example, I'm sure one of the things you're going to say, if you're riding a bicycle or especially a motorcycle, wear a helmet.
Absolutely. Thank you for bringing that up. The best way to help in TBI care is to prevent them from happening. So if one is engaging in an activity that could be at risk, mitigating that risk is what we seek to do. When driving in a motor vehicle, buckling a safety belt is paramount. It's something really easy and they're in all vehicles at this point, I would think. When riding in an exposed vehicle, such as a bicycle, motorcycle, or ATV, we do recommend helmets. Similar, when doing high-speed activities, perhaps skiing, that might be a time for helmet or other protective gear as well. We always encourage health in a global sense, so abstinence from substance abuse or getting behind the wheel of a motor vehicle intoxicated is something we would encourage by all means.
So let me ask you this. As a parent that has children participating actively in sports, in your professional opinion, let's assume, and I'll make this up, but let's say it's a 12 or 13-year-old and they're playing soccer or football and they have a concussion and they seek treatment for it, a medical treatment, and they come back and play when it's safe for them, but they incur another concussion. When do you decide, maybe I should stop participating in sports?
That's a great question. We have an excellent team of pediatric neurosurgeons under which I train that help me understand the answer to that question. A concussion comes from a blow to the head with or without loss of consciousness. This can lead to temporary cognitive symptoms or more permanent symptoms. Oftentimes with that are associated physical manifestations such as headache, blurred vision, impaired concentration, or even nausea with impaired ability to keep down one's food and sustain kind of the normal activity that you would for a child. One concussion is bad enough. What we call a second hit can compound the initial impact from the original concussion. When children are involved in competitive sports and they undergo a second hit, we worry about their cognitive development from thereafter and would think that we'd have to really consider putting them at risk in the same sport or activity that begat the injury to begin with. It's one of the hardest things I've ever had to counsel is when a youth has a great future ahead of them in a competitive sport, and for their long-term health, I need to counsel perhaps they need to abstain from that sport in the future despite the enjoyment or promise that it had for them. But often the parents are very thankful when we do have to cross that bridge, that we're honest and open about it, giving them the choice as well as the potential consequences so that they can make an informed decision.
So the number one message here is if you've had a traumatic brain injury and you suspect that something might have occurred, you need to get to the hospital. Now, what is going to happen when you get there? Well, let's take a little bit of the mystique out. So Dr. Hoes, could you tell us what might be next in this path?
Sure. As soon as they come to the emergency room, they're greeted by staff that ascertain who they are and what just happened. They're taken from the presentation area, depending if they're brought by their family or the emergency medical service staff in an ambulance, to an area of an acute assessment. They're seen by a physician and likely a team of advanced practice providers such as physician assistants or nurse practitioners that go through every step of history for crucial elements, physical examination for the basics of life, airway, breathing, circulation, and a neurologic assessment. Based on looking at that and vital signs, they will deem how stable the person is to be moved from that spot for additional either resuscitation or advanced imaging. It's very quick and easy in the emergency room to go from assessment to imaging. They're very closely located in proximity to ensure that we move from one setting to another seamlessly. So I'd anticipate if the patient is stable with their vital signs, then they go to an imaging such as a CAT scan that is immediately seen by a radiologist and a report is generated for the next step in action. There are also preventive things that are happening, such as making sure we have appropriate intravenous access for emergency medicine use, maybe giving oxygen in case the patient is not wakeful enough to do appropriate breaths on their own, and kind of a tiered system of evaluation based on imaging findings. It's extremely rare to go to the operating room directly from the emergency room unless there is a clear sign of what has just happened. In some very unfortunate cases, such as gunshot wounds to the head with an immediately unstable individual, we need to make a quicker course of action and more direct intervention. But even in that emergent situation, we often can stabilize someone enough to get an image before we move to the next setting.
Dr. Kathryn Hoes, thank you so much for great tips about our control center of life, our brain. Now, when we come back, we're going to take a different tact on a familiar topic. We're going to talk to Max Stewart. He's with Hall Render here in Dallas, a law firm. We're going to discuss the vaccine around legal perspectives. This is a fascinating conversation with questions you're going to want to know. Next on The Human Side of Healthcare.
Welcome back to the Human Side of Healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
And welcome to the Human Side of Healthcare. We're delighted that you're with us today. And we've had a lot of people on the show, medical experts, physicians, infectious disease docs. We thought today we would bring in a good friend of ours, Mac Stewart. Mac is with Hall-Renda, and Hall-Renda has been a big supporter of the Dallas-Fort Worth Hospital Council for a number of years. And we want to ask some legal questions related to COVID-19. Mac, welcome to the show.
Thank you, Steve. It's an honor to be here.
Mac, there's a lot of talk about COVID-19. We've been talking about it for 14 months. But Hall-Renda is throughout the nation. You've got clients that you deal with, employers from every aspect of industry. Why do you think there are people that still have vaccine hesitancy?
Well, Steve, as you know, we tend to specialize in representing the healthcare industry. And our experience with the employees in the healthcare industry is they're just like the general public. You have folks that don't trust science, even though they make their living in a science-based industry. You have people that want to know more than they've been told. They want more information before they're prepared to be comfortable to take vaccine. You have people that don't want to do it for religious reasons. Some people think that they're being told to take vaccines, which they're not, but they don't like being told what to do. And some have a general anti-vaccine approach to life. So the healthcare industry is a microcosm of the entire populace. And so the reasons that apply generally also apply within the healthcare industry. There is a great push within the industry to educate their own employees, but you're still going to run into some hesitancy.
You are exactly right. I think when you look generally across the nation, about 99% of the physicians have taken the vaccine, and about 65 to 70% of the other employees. So we're going to have to continue to educate. When you look at employers, can they legally mandate that people take the COVID-19 vaccine?
Steve, that's a fascinating question. Part of the problem in giving a definitive answer to that question is, as is typical, the law lags behind whatever happens in the real world. As a general proposition, employers can mandate the vaccine, but people can opt out of it for religious, ethical, medical reasons. The EEOC, the Equal Employer Opportunity Commission, has come out and said you can require it, but if someone opts out due to a disability, and the disability definition under EEOC is very, very broad. But if you opt out, but the employer thinks that you still pose a risk to others, they have to make an accommodation. And if they cannot make the accommodation, they can exclude you from the workplace. But that doesn't mean necessarily that they are allowed to terminate your employment. It becomes very complicated when you add in the vaccine aspect to the overriding regulations of the EEOC. That then bumps against what the FDA says. The vaccines now are all under emergency use authorization. And the FDA and Congress have effectively said you're allowed to choose to take it or not choose it because it is an emergency use authorization. So on one hand, you've got the FDA saying you can't require someone specifically. You got the EEOC saying you can, but there are exceptions to that. And then we've got states. I've done a small search of what is pending in the Texas legislature. One bill, it's House Bill 1687. It's still working its way through committee, but it's interesting. That bill will prohibit employment agencies from referring someone for employment to a third party. They are prevented from not referring when they're not vaccinated. So Texas is taking the position, generally speaking, that you don't have to be vaccinated to work. And I think if you're outside of the EEOC protections, then I think they can mandate it, but I think there'll be more exceptions than the rule.
So from a legal perspective, is there a chance if employers try to mandate it, there could be employer blanket liability?
Yes, I think there can be. The reality is there will be people that will want to resist this, and they will, in fact, play off the FDA versus the EEOC versus state law. This will be a set of litigation that I think will go on and on for years.
You know, Mac, we've heard a lot about vaccinations, travel to other countries. What are the legal ramifications of a vaccine passport?
If I may, I'd like to maybe recast that question a little bit. I think the question is, are we likely to see laws requiring vaccine passports? I think that will come down to a state basis. And whether we like it or not, we are still an incredibly divided country, red and blue. I think red states will not require a vaccine. Governor Abbott has weighed in strongly that he's not going to require a vaccine. Santos in Florida has weighed in heavily. I think some blue states may require the vaccine. And the federal government may do that too. But I think ultimately these all will be attacked on privacy and constitutional grounds. I think eventually it will come down to the individual employer level. And then we come back to the push and pull between the FDA, the EEOC, and state law. So businesses will require vaccines. There will be litigation over it. There will be people that want passports. There will be people that do not want passports. There will be litigation over that. So at this stage in the game, one cannot say definitively that vaccine passports will be a requirement. If I were to guess, my guess would be in this country, in the United States, vaccine passports will not be required.
Talking about legal ramifications, and I know this is requiring you to kind of look in your crystal ball, but people have recently been concerned about adverse reactions to some vaccines, like the Johnson & Johnson. In fact, AstraZeneca has not been approved here yet, and we're already hearing about also blood clots there. But from a legal perspective, should the public be concerned over what they're seeing and what they're experiencing?
Steve, I read an interesting article recently. It was addressing the issue of old risks versus new risks. There's a federal judge law professor in California that asked one of his first-year law classes the following question. If I told you that we would invent this magnificent piece of technology that would make life easier, allow you to have a freer life and do more things that you wanted, but you would have to sacrifice 1,000 young people every year, would you do that? And the resounding answer from the students was no. This judge professor was talking about automobiles, because about 1,000 young people a year will perish in automobile accidents. The point he was trying to make was that's an old risk. We accept that risk every time we get in a car. We accept that risk. The vaccine risk, particularly the COVID vaccine risk, is a new risk, a risk that a lot of people don't understand. And for that reason, people, I believe, and this is really a personal opinion as much as anything else, are going to overthink the risks. I may have mentioned to you in the past, my family and I had a benefit. I have a son who's a microbiologist. He's getting his PhD in evolutionary and ecological microbiology. So we got him on the phone. Said, son, tell me about this. He explained the vaccine. He explained how they went developing each individual vaccine. What I found particularly interesting was the messenger RNA vaccine that Moderna and Pfizer use is not new technology. The proof of concept was made 20 years ago. It's just that now there was finally a need for that type of technology on a massive scale. So people don't understand, for example, that the messenger RNA is proven technology and it doesn't create problems. but it's a new risk as opposed to an old risk. So from a legal standpoint, I think that the vaccine companies are safe. I don't think they're going to be sued. I don't think they'll be sued. People sue, but I don't think they'll have legal liability. The risk of the J&J is, and it's for the person that suffers this risk, it's 100% risk, and it's very devastating. But the latest I heard is about 1 in 500,000 have a risk of the blood clot. Well, about 50 out of 500,000 people will die from COVID. So when you do the pure math, you go the risk of 1 versus 50, it's a reasonable risk for everyone. But again, we're still fighting this idea of an old risk versus a new risk. I believe that as time goes on, and as the healthcare industry, as they should, and as federal, state, and local governments, as they should, educate patients and the public, that I think the risk of the COVID vaccine will become an old risk, like the risk of getting into an automobile, and it will be generally accepted. You'll still have the outliers who, even when having all the information, choose to make an informed decision not to take it. But I think the legal liability on providers and the drug manufacturers will be minimal, if at all.
This is Mac Stewart. He's with Hull Render here in Dallas, and we're going to talk about the NFL's recent decision of what they did around the vaccine next on the human side of healthcare. Stay with us.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're picking up with a fascinating conversation with Mac Stewart. He's with the law firm Hull Render. They're nationwide, but of course have an office here in Dallas. Interestingly, Mac's wife, Patty, is an RN, so they know this space very, very well. Mac has covered all areas of healthcare representation in his career. And we're going to pick back up with a question about what the NFL did around this whole thing of vaccination and the employer-employee relationship. Steve?
Circling back a little bit when we were talking about employers requiring the vaccine, I think the National Football League recently required COVID vaccines if you're going to play in the NFL. So I'm just wondering if there will be legal challenges on that, Mac.
I suspect not, and it's for a very practical reason. The men who play in the NFL have worked most of their life to be in the NFL, and there are a very small percentage of people who have had an opportunity to play football. And I don't think the vast majority of them are going to fight the fact that they have to have a vaccine because it's too important to them. And I think that will also be true in many other industries where you will take the vaccine because the risk of not being able to do what you want will outweigh whatever perceived risk you have of the vaccine.
You know, Mac, our hearts ache for not only the people that have suffered from COVID-19, but it's had a devastating impact on a lot of business and industry. And we know that many of the restaurants, we know that many of the bars and taverns, we know that many of the cinemas have all been negatively impacted, and they're striving to come back. But from a legal perspective, many people ask, is a pandemic something that could qualify as business interruption? You have any thoughts on that from a legal perspective?
The basic issue with business interruption is a contract issue. What are the terms of your contract? If we step aside, we think morally and ethically, of course this is a business interruption by something I had no control over. Of course, it's what we would call in the law an act of God. But if the contract terms don't provide for it, then you won't have coverage. I will tell you what I now do in virtually all of my contracts. I include an act of God clause, and I specifically spell out epidemics and pandemics, so we have no question whatsoever. This will be a huge piece of litigation for years to come. I suspect that we won't see a lot of cases go to final judgment, because the worst thing that can happen for an insurance company is for someone to interpret a clause as saying it does apply to pandemics. If people are listening and they are worried about whether they can recover under their insurance, I say try. And I say try vigorously, because I think at the end of the day, there'll be a calculation by the insurance companies of, do I want a judgment that opens up the floodgates, or on a piecemeal basis, will I try and resolve these disputes? There have been a lot of businesses that have done very poorly. I can speak to healthcare providers, and there have certainly been slowdowns that have hurt business during the first and second waves. But most physician practices and hospitals are recovering nicely. We have seen a massive increase in business transactions. We do some work in the private equity field. Private equity is still involved significantly in healthcare. It might have slowed down a bit, but we suspect that is they're waiting to try and get the best possible deal there is. I have a son that works in the private equity world in healthcare, and they're being very aggressive trying to expand their portfolio. So business interruption is a real thing. Those businesses that have been interrupted, I would counsel, call your carrier, fight over it. And then in the future, for every business that goes out and buys business interruption insurance, you make sure it specifically refers to epidemics and pandemics. They have different definitions. I would include both in there.
Hi, Mac. It's Thomas Miller. Is there anything related to international law that we should consider here?
That's interesting that you asked that question. I mentioned my son who's getting his PhD. He's at VU University in the Netherlands, and he can't get home, and we can't get over there to see him. International law will have a tremendous effect on the multinational corporations and people trying to get here and there and elsewhere. So I think anyone that is considering doing business overseas or traveling overseas needs to do their homework, because some places are still massively shut down. Some places are wide open. And with Brexit, Britain is doing things differently than the EU. And I don't think you can go in and assume, looking at any individual country or region, that it applies across the broader region.
You know, I've been reading, as I'm sure many of our listeners have, a lot of different perspectives on all of this, and I see the conversation of, it's the idea of human rights. What am I allowed to decide to do with my body versus the common good? What are your thoughts on that?
That's an interesting concept. In the United States, particularly in the area of healthcare, which would involve vaccines, we have this very strong concept of informed consent. And that is, you tell what the ordinary and prudent person would want to know in order to make an informed consent. And we believe strongly in allowing informed consent. I can tell you that I've had cases over the years where folks are in a hospital and they decline treatment. And my clients will call me and say, they've declined this treatment. They will die without this treatment, to which I say, that is their right. So we have this strong informed consent ethos that we have in this country, but we also have this strong workplace safety. Workplace safety can bump against what might be generally called human rights. And it's a continuing balancing act between, for example, workplace safety and human rights. I think that's one reason the EEOC has specifically said that one can opt out of a vaccine as a result of, again, broad definition of disability. And that's an exercise of a human right. But the employer has a broader mandate in that the employer needs to protect all employees. And that's why, even though one might argue it's a violation of a human right, if it poses a threat to another, that you can take actions. We can wave our arms out there, and it's fine to wave our arms until we wave our arms and we hit somebody. And that's not allowed. We just can't do that. So the human right ethos, I think, is built into the concept that you will be allowed to opt out, but you cannot, through your opting out, put someone else at risk. In Texas, there is a law that requires some healthcare providers to either be vaccinated or opt out for religious, ethical, or moral reasons. That's very specific to healthcare providers, but it doesn't say we have to see the shot go in your arm. You just have to tell us you were vaccinated. COVID's not on that yet, but that's an example. And I've had cases in the past where physicians, for example, don't want flu shots. And we say to them, we're sorry. This is what is required for a specific kind of healthcare provider in the state of Texas. And they argue, I have a right not to do it. We then say, well, we have a right to say, then you can't practice in this hospital. It's the balancing of the risks versus, as you say, the human right to make all decisions with regard to your own body.
You've been listening to Max Stewart, an attorney with Hall Render, a firm with an office here in Dallas, but also nationwide that represents and does a lot of work in healthcare. That whole conversation is on our podcast, The Human Side of Healthcare, on all the major podcast players. Steve?
Hey, what a great show. We've really appreciated you being here. In the meantime, please stay safe. Wear a mask, physical distance, wash your hands. We want to keep you good and safe, so you'll join us next week.